Good evening, guys. Welcome to the CME today. My name is Dr. Soy Siovata. I am a member of the KMA Physician Wellbeing Committee, which is hosting this webinar today, and I'll be your moderator. Kindly we'll have a presentation. Then you can put any of the questions you might have on the Q&A box, and then we'll address them after the presentation. This webinar will be recorded and uploaded on YouTube for reference purposes. So tomorrow is World Suicide Prevention Day, the 10th of September, and we will be honoring it with this webinar on changing the narrative about suicide. Often suicide is spoken about in hush-hush manner and surrounded by judgment, which only makes things worse for the victim. Often compassionate and supportive conversations will steer this ship in the right direction and encourage empathy and timely intervention and prevention. Our speaker today will be Dr. Musheru Wangombe, who is a graduate of the University of Nairobi, Bachelor of Medicine and Surgery, and Masters of Medicine in Psychiatry. She was awarded Best Distinction Student of the Year in 2006, 2007. She's a consultant at Mathare National Teaching and Referral Hospital. She's the lead psychiatrist at Healthy Mind Consultants, a one-stop shop for one's mental health needs. She's also a founder member at Camille Organization, a mental health NGO providing subsidized community mental health services, sponsoring nurses' higher diploma in mental health and providing loans to clients. Her interest areas include telepsychiatry, mental health promotion, and youth mental health. Besides pursuing her passion for mental health, she enjoys swimming, gardening, travel, and creating memories through taking photographs. Karibu sana, Dr. Musheru.
Thank you very much, Dr. Soy, for that kind introduction. It's my pleasure to be discussing suicide prevention on a day like this, when we are moving away from stigma associated with suicide and being empathetic, creating this conversations either as clinicians, as family members, as members of a community, as governments. And we are all hoping that through these continued efforts, then we are going to make suicide preventable. We are going to save a life each day and to emphasize the fact that each life matters. So you'll allow me to share my presentation. So I will be tackling this topic of suicide, changing the narrative. I'll explain why the title. My outline for today's presentation will be as follows. I want us to know the genesis of World Suicide Prevention Day, to discuss the Suicide Prevention Strategy 2021 to 2026, sorry for the typo, and also to discuss suicide, the role of physicians when it comes to suicide, and how it is that we can prevent and how we can cope with situations where we as physicians lose patients to suicide. So World Suicide Prevention Day has a rich history. And this is as a result of efforts by the International Association for Suicide Prevention, World Health Organization, and World Federation for Mental Health. So it is meant to be an opportunity for us to create awareness and to emphasize the fact that suicide is preventable. Now, when we talk about suicide prevention, a specific day was chosen in 2003, and the day happens to be September 10th every year. So since 2003, it has been celebrated, and the activities would run all the way from a week, culminating in the final day, which then is Suicide Prevention Day, or even for an entire month, depending on the funding and the various activities that are organized, either at individual level, community level, organizations, governments, and as much as possible, there is usually a theme. So the theme of the World Suicide Prevention this year is a triennial theme. So it has been running for the last 3 years. And that explains the generation of my title, Changing the Narrative. And we are going to see how we are going to change that narrative so that we move away from the stigma associated with seeking help for suicide, suicidal behavior, to a situation where we bring people close to getting help and prevent deaths. But before we go ahead, I would like us to acknowledge the fact that with Suicide Prevention Day, we also remember those we have lost in the past. And I would like us to take a minute to reflect on anyone who we may have lost to suicide, or those who have struggled or are still struggling with suicidal behavior. Today, I would like us to acknowledge the late Charity Muturi. She was one of the petitioners for decriminalization of suicide in this country. She was a person with lived experience, and I would like us to take a moment to remember those who we have lost to suicide. I will then continue with the presentation. The history of suicide prevention dates back to the ages where probably it was considered to be a sin in the religious circles, and people were considered, or people who had died by suicide were considered to be like outcasts in the society. Now, from that kind of, so that suicide is not a religious issue, it is not a cultural issue anymore, it has become a mental health issue, and I'm going to explain why. So initially, suicide was viewed as a sin or as a crime, and there was very little effort geared towards preventing it. And there were efforts to things like atonement, and so that it was looked at as something that nobody would want to talk about. Unlike today, when in the early 20th century, for example, in 1906, there were efforts to focus on individuals so that we had initiatives like National Save a Life League, which was in New York, or the Salvation Army in London, who then focused on individuals and how it is that individuals can be helped to prevent suicide. Then in the mid 20th century, that is from about 1958 to 2001, then people started understanding this from a public health perspective. And this was marked by, for example, you would have means restriction. Like, for example, in the UK, they changed from the composition of coal gas because they discovered that this was one of the means to attempted suicide, and sometimes people would die because of the coal gas. So they changed the composition, and this was shown to reduce the amount of the number of suicide cases in that specific region. Then in 1998, for example, no, 1958, the first suicide prevention center in the US was opened in Los Angeles. And this now started the professionalism when it came to prevention of suicide. Late in that century, or in the 20th century, there were conferences that brought people together to discuss this as a public health issue. Then now, come the year 2003, there was the global and coordinated action, which we are part of now. So that World Suicide Prevention Day since then has had a specific theme. And this is meant to spur the conversation, to have various efforts to make sure that suicide is no longer a taboo. It is no longer something we mention with undertones. It is something we can talk about. And by talking about it, it makes it easier for people to understand and also to seek help for those who are suffering. So the changing on suicide is the theme that we have for the years 2004, this year, and next year. And we are looking at moving from silence, where it was nothing to be talked about, it was taboo. We are looking at the stigma associated with it and the lack of understanding. And hopefully, we are going to encourage openness when it comes to talking about suicide, encourage people to empathize with those who are suffering, either because they have attempted suicide or are contemplating to attempt suicide, and to find support for the various individuals. So when we talk about the openness, it's no longer a situation where because it's a problem across the lifespan. So we would want that as young people grow up, they get to know there's a problem, that suicide is something that should be addressed right from the gatekeepers at the school, the teachers, the guidance and counseling teachers. And we would need that. We don't wait for patients to come to hospital, but we go out there, promote good mental health, promote health-seeking behavior and self-care practices that can prevent people from coming to hospital. So now, what are these? How do we change this narrative? One, we need to open these conversations like we are doing today, instead of a situation where people do not get to know what are the risk factors of suicide, what are the protective factors, what can we do to help, including checking in on someone. When is the last time you talked to, I mean, there are people who seem to have it all together. You haven't talked to them in a long time. Why don't you check in, find out how they're doing? These can actually interrupt their suicidal thoughts. There are situations where people have been thinking about suicide and they have the thought, they have been thinking through it, then they get this phone call from somebody who talks to them and it makes them turn around. It makes them feel that they belong. It makes them feel they are not alone anymore. So it's important that as individuals, we open conversations, you pick up your phone, check on someone, text somebody, ask them not just hi, ask them how you're doing, ask them probably what they are going through, because that can open a can of worms. It can actually be the way in which somebody does find help. So as individuals, we need to check in on loved ones, check in on colleagues, check in on your neighbor. I know it's a bit of a tricky situation where people live in urban populations and not many people know who their neighbor is, but the fact that you checked in on them may actually save a life today. What about policy? How does policy help us change this narrative? Decriminalization of suicide, for example, in this country, we have Section 226 of the Penal Code, which is yet to be repealed. We were very happy about the fact that it is now not constitutional, or you cannot be charged in a court of law with having attempted suicide. So we are looking at a situation where we have moved from it still being in the penal code, so it needs to be repealed because it is still a crime to attempt suicide in this country, and it can attract a prison sentence. But what we are saying is, from the ruling that it is unconstitutional to charge somebody with a suicide attempt, that is a milestone. But we still need to pursue to make sure that it is the suicide as a crime is repealed from the penal code. And then we have a suicide prevention strategy by the Ministry of Health, which I'm going to talk about this evening, from the year 2021 to 2026. So it is available as a hard copy. It is also available as a soft copy. And I will encourage Kenya Medical Association to share it on the YouTube page so that each of us is able to have a look at it. Then call to action. We need to do trainings. We need to identify specific target groups and train them on how we can prevent suicide. Sharing stories. Sharing stories helps demystify and it helps destigmatize suicide or suicidal attempts. So we are talking about somebody who has been through this and is able to share a story about how it is that they got help. And this would help also others who are able to, so that they're able to seek help. And they do not just keep quiet, suffer in silence, but they need to, we need to demystify and to encourage people to seek help. Checking in with loved ones is very important. That is part of the action areas. Then conflict. In war situations, in places where people are undergoing disasters, floods, whether it's floods or people have been victims of an earthquake or any such natural or man-made disasters, it's important that those in crisis are encouraged to seek mental health care, and we are going to see why. Because what happens is people at risk are these people who probably are having a financial crisis, or they're having an economic crisis, or crisis in their life. They tend to be more of at risk of attempting suicide. So in other countries, for example, in Ireland, they have been looking at specific ways in which, in addition to reaching out to someone and checking out on them, your words also matter. I must say that the International Association for Suicide Prevention has language guidelines. What do I mean by this? People may forget what you said about them, but they'll never forget how you made them feel. So please remember to speak with kindness and respect. The people who have attempted suicide or have lost loved ones, colleagues, neighbors, name it, they deserve to be treated with respect and dignity. So then, what kind of language, or what is the lingua we should use? This person died by suicide. Many times we catch ourselves saying they committed suicide. So what are we saying? It's like they committed a crime. Let's avoid using terms like they had a failed suicidal attempt, or they had a successful suicide. As much as possible, we would like to use terms like died by suicide or died of suicide. And then let's avoid using completed suicide. It creates the notion that this person had tried many times. Then now, just like a job, it got complete. So completed suicide. While in fact, probably it was their first time. And unfortunately, they died by suicide. Then responsible media reporting. I need to emphasize this so that as much as possible, media should avoid reporting the methods used for suicide, because this will encourage suicide copycats so that people will use the same means. In contrast, they should actually be, as much as possible, providing maybe hotlines or encouraging people to seek help, as opposed to vividly describing how or the method the person used. Then let's be safe online. What do I mean by that? We are in the era where we like sharing a lot. Sharing is caring, but remember what you share. It's important to share something that would help somebody else. I know because of COVID, there are some buttons that probably, like WhatsApp, you can only share in this number of groups, so that this reduced the amount of sharing information and people getting anxious and consuming or binging on information. Remember, this information is with us. and you have the share button at your disposal. But please think before you post, think before you share something, so that we are sharing information about suicide and self-harm responsibly. Remember, you need to acknowledge that even if it is about somebody who attempted suicide, these people, I mean, they're entitled to, or they require confidentiality, so that it's not you share it and make it go viral, and now we find it difficult for you to even filter, so that you find that somebody is just sharing and resharing information. Kindly let us think before we post. So this we are borrowing from other countries, and this is something that applies to all of us. So what is the epidemiology of suicide? Let's look at the numbers. Now, we are looking at a death every 40 seconds. If I would ask you to think about COVID-19, it was easy to tell people to wash their hands, sing happy birthday twice, the song, and that would give you 20 seconds. Now imagine singing it 4 times and there is a death. Singing it again 4 times, there is another death, and the death is to suicide. We are talking about an average of 3,000 deaths daily. This means that 1.4% of all deaths worldwide are accounted for by suicide. And these deaths, the 1.4% is even more than can be accounted for by murder and war. So that both combined would not give us 1.4% of the deaths. And the highest rates of death are those aged 70 and above. We have good news that our life expectancy now is about 73. So what are we trying to say? Many of our, many people in our population will get to 70. But what will happen is then the risk for suicide is higher. There is a difference between the risk for suicide, males and females, or depending on the sex, meaning that suicides are more common among males than females, and it depends on which part of the world we are at. For example, if you're in the developed countries, then the risk of the ratio now differs, so that you may have as much as 3.5 to 1. So 3.5 times, 3.5-fold increase in male deaths as opposed to female deaths. In our part of the world, where we're in the middle income countries and probably low income countries, then we find that the ratio is 1.5 to 1. And it's important to mention that men attempt suicide less than females, but use more lethal means. So that means then they succeed more than the females. Females will attempt more than males by maybe 2 to 3 times, and you will find that the suicide is more among males than females. Now, we are talking about 700,000 to 1 million deaths annually, meaning suicide is the 13th leading cause of death worldwide. And now, among young people between 15 and 29, it is the fourth leading cause of death. So this is an important issue, and we need to understand that by preventing suicide, we will have saved many of these lives. What about in our country? We don't have too much data, but the data we have is that we have most of our patients presenting with common mental disorders, that is anxiety and depression, so that in outpatient settings, 1 in every 4. But when it comes to general outpatient, for example, or the general consultations in hospitals, you find that 4 out of 10 of the people on our queues have one mental health problem or not. And usually it's not, they will not talk about it unless you ask them. And the question can be as simple as, are there times you have felt like life is not worth living? And that can actually be the beginning of the patient not going to doctor shopping, because now they will go to the hospital, they will find that this hospital is not finding their problem because all labs are normal or imaging is normal, the patient is still suffering. They'll move from hospital A to B, C to D. They will move from clinician to clinician trying to get help. But by asking the relevant questions, by screening our patient, then you will find that we reduce this health, the fact that it takes so long for them to get help and for them to get the right diagnosis, and therefore that delays treatment. Now, suicidal thoughts associated with depression have a lifetime prevalence of 7.9%. And those associated with other mental health illnesses or mental disorders are about 5 to 8%. So what are the universal suicide prevention strategies? The first one is restricting the means. So if, for example, like in Kenya, for you to own a firearm, you need a mental state assessment. That is one of the examples of restricting means to suicidal, to a means of suicide. And that in itself is a lethal means. What about pesticides? It would be important that we have a policy on pesticide control so that actually restricts who can buy pesticide and from which outlet, and this would help us reduce suicide. The fact that medications, for example, prescribed medication, you would need a prescription to get various medications as opposed to walking into a pharmacy, and since you look presentable or you have the money, you're given the medication and you go and harm yourself. Number 2 is treatment of mental health disorders. It's not just anxiety, depression, can be bipolar, substance use disorders, personality disorders. Mental health disorders need to be treated and treated promptly. The earlier you diagnose the mental health condition and start the person on treatment, whether it is psychotherapy or pharmacotherapy, the better. Crisis hotlines, meaning you need immediate and confidential support. If, for example, there is a hotline that you will call, somebody responds, then that would help you get immediate help. And for sure, if it is confidential support, then more and more people will open up and less less of them will find themselves attempting suicide or dying by suicide. Now, we need to raise public awareness so that each of us is able to identify warning signs, so that if someone is consistently talking about wanting to harm themselves, or the fact that life has no meaning, or that the world would be better without them, what is called a situation where you feel life is not worth living, and you don't see why you should live an extra day, and you actually feel that the world would be better without you, then that would be a situation where we need to identify these people and link them with help. Then data collection and research. It's important that we collect data using our electronic medical records and use this data to develop evidence-based intervention for suicide. So, for example, electronic medical records would be a good way, or it would be a way in which we can collect data as regards suicidal attempts, death by suicide, and use this to give us evidence-based interventions. So let's talk about the suicide prevention strategy by the Ministry of Health in this country. The goal is to reduce suicide mortality by 10% by the year 2026. And there are various strategic objectives. For example, suicide prevention program at both national and county level, to strengthen supportive policies, for example, repealing of Section 226 of the Penal Code, and develop a pesticide control policy in conjunction or in collaboration with the Ministry of Agriculture. What this means is that suicide prevention is a complex issue requiring a multi-sectoral approach, so that it's not just a health issue. We need to involve the Ministry of Education, the Ministry of Labor, the justice system, the Ministry of Agriculture, so that we strengthen various supportive policies that may help with suicide prevention. So that if it's access to the means, we are working with, for example, the licensing board, firearm board, to make sure that those applicants for firearms, those renewals are done by people who have undergone a mental state assessment, to reduce the possibility of someone who is applying for a firearm because they need to protect themselves, and yet they are paranoid. And that can actually then, should the person own the firearm, then they may be a risk to themselves or others. Then comprehensive, the increasing access to comprehensive mental health services, then designing training packages, and strengthening systems of surveillance and research. Now, there is a specific, there are specific committees that are charged with reporting back about how far these strategic objectives have been achieved. And this is something that probably will be presented to you in the future, so that we would want to know between 2021 and 2026, what have we achieved as regards one, suicide prevention programs at the national or county levels? How many programs do we have at the national level? Does each county have a suicide prevention program, and how is it being implemented? What support policies do we have by the end of 2026? Do we have comprehensive mental health care services so that in each county, in each referral hospital, there should be comprehensive mental health services? And then, is awareness creation a continuous thing? Because it's not just about awareness creation around World Suicide Prevention Day, World Suicide Prevention Month, or World Suicide Prevention Week. No, we would want that it is something that is ongoing. If it is incorporated into the school curriculum, for example, that would be quite useful. And training the gatekeepers, like for example, if it is the teachers, is suicide prevention part of their training? If it is the police, is suicide prevention part of their training? Then research, can we get more of the local statistics and see how it is that we can use this local data to make sure that we're able to implement the suicide prevention strategy? Now, when it comes to evaluation for suicide, we would want to talk about the risk factors for suicide. These include individual factors, like, for example, the fact that you've had a previous suicidal attempt, you have a mental health problem, or mental health disorder, or mental disorder for that matter. One is using substances, and you've encountered a loss, either you've lost your job, or you lost property, or you're in any chronic pain, or you suffer from a chronic illness, and family history of suicide, genetics, so that depression, for example, runs in families, especially, and so does alcohol use disorder. So then family history of suicide is one of the important risk factors that we need to look out for. And when we come to screening for suicide, what we call third persons, these are some of, it's a mnemonic to actually try and identify the various factors and score the patients so that you're able to tell who may need closer observation, who may need immediate hospitalization, or who may need hospitalization for further evaluation. So what about the community? So at the individual levels, those are the risk factors. What about at the community? If there is either a man-made disaster or a natural disaster, people are getting discriminated for whatever reason. Trauma. When we talk about trauma or abuse, I don't want to leave out the effects of adverse childhood adversities or adverse childhood experiences, where probably children are exposed to domestic violence or physical, emotional, sexual abuse, or they have someone in the family with a mental health problem, or they have someone in the family who has been imprisoned, or they have witnessed somebody shouting at the other, and probably maybe some people who are getting physically violent. And this actually does lead to mental health problems later in life. Now, sense of isolation and lack of social support. Now, loneliness is a new disaster that we are experiencing, and loneliness can now lead to thwarted isolation, where people feel like I mean, they're on their own, they have nobody to talk to, probably. Then they have, I mean, they have no social support, and this can actually lead some of the risk factors to suicide. Relationship conflict, discord or loss, including breakups, are risk factors for attempted suicide or suicidal behavior. What about health systems? Barriers to accessing care, whether it's lack of transport or the healthcare providers, for one reason or the other, are not able to provide care. Either there is a strike, a go slow, and that is the time you need the help, or probably then there are no accessible medications for you. So these barriers are accessing healthcare. Then access to means of suicide. That is why, as much as possible, those policies that would restrict access to means would be very useful. Then inappropriate media reporting and social media. There is cyberbullying, and cyberbullying can also be a risk factor for suicide. Stigma associated with health-seeking behavior, so that somebody would rather they don't seek help because then society will disapprove of them, and probably even the healthcare provider will not be sensitive, will not be empathetic about this person who is seeking help. Now, it's important that we ask ourselves about loss of patients by suicide, because we take care of patients, and once in a while, you might find that you lose a patient, and unfortunately, the patient dies to suicide. So there are specific themes that do affect us, and what is the most likely is the fact that we get traumatized as physicians, and you will find that you're having situations where you're feeling distressed, you're lacking sleep, you're having distressed dreams. You might find yourself crying, feeling very sad, feeling angry at yourself, feeling angry at the facility, feeling angry at your colleague, and feeling the sense of loss. Imagine this patient you have been seeing for quite a time, and now suddenly they died, and you can't help asking yourself, what could have gone wrong? What did I do, or what didn't I do that made this person take their life? Because suicide is defined as intentionally taking one's own life. So then, is there something I did? I mean, a mistake of omission or commission, something I did or didn't do that made this person decide to take their life. Then treatment-specific relationships, so that there was a relationship between the doctor or the nurse or the healthcare provider with this patient or their family. So then how does that relationship now go? Now, whenever they see you, they think, okay, or whenever they see the specific facility, they say, now that is the place where our loved one passed on, or that is where the person took their life, probably when there was a changeover or something like that, and the patient then managed to take their life during that time, especially when staff are changing shifts. Then probably that's a time when there's a lot going on, others are changing, these ones are coming in, and the patient may take that opportunity to take their life. What about other patients? Supposing the patient passed on in a facility, and the other patients now know the person died. I mean, how will you be the same doctor seeing the patients, and especially those who are suicidal? So you may now not want to be interviewing or be taking care of any patient who mentions self-harm or who presents with self-harm, because you're scared or you're afraid that this person may also lose their lives. Then what about relationship with colleagues, supervisors? It becomes a bit tricky, because then there might be a blame game. Oh, yes, you're the one who showed up late, or probably the medication, you didn't prescribe the medication on time, or there was one thing or the other that may have led to this happening. And usually there is also the risk of, there are risk management concerns. Well, things may go wrong and something may happen and there might be a lawsuit. So then now what happens to you? What happens to the institution? How are things gonna be after all this? Then now there's the fact that people feel guilty, there is judgment, there is a sense of blame, and sometimes you as the clinician may feel like you're not competent enough because you lost this patient. After all you had done, the patient still died by suicide. Then you now start having an imposter syndrome and wondering, well, did I really qualify? Am I good enough? Or is there something wrong with me? Am I able to take care of patients any longer? So what about the organization? Like, for example, if it's a hospital, how do they handle this situation where probably a patient has, the death of a patient by suicide has occurred at their facility? Then there will be a root cause analysis. There will be most likely a mortality meeting, trying to identify what could have gone wrong, what could have been missed, and what probably may have been the cause of death, and what sometimes may be called a psychological postmortem, so that people will try and look back and see, could there have been a diagnosis that was missed, that this person was suffering from probably bipolar or major depressive disorder, which was not treated, and therefore now would account for or would explain why it is that the person took their lives. Unfortunately, sometimes it leads to a blame game, or who did not identify or who didn't make the diagnosis, and therefore that is why we are where we are right now, in a situation where we've lost a patient. Now, I would now want to shift to the public health perspective, other than now the clinical area, where organizations can also help change the narrative, and they can help with suicide prevention. How? One, education, so that, and training, so that, for example, their clients, when sitting at the antenatal clinic, are talked to. They're given educational talks, and the importance of seeking help early is emphasized. For example, depression in pregnancy, or even depression postpartum onset, has been shown to occur, at least 50% begins in pregnancy. So as the client sits at the antenatal clinic, that's a perfect place to get them and educate them and tell them, well, if you're feeling low, you have a low mood nearly every day for at least 2 weeks, accompanied by loss of interest in pleasurable activities every day or nearly every day, then it is important that you seek help. And probably they get screened using a patient health questionnaire too. It has two questions, which just ask about the low mood and the lack of interest in pleasurable activity. That may help with screening patients, for example, in an antenatal clinic, and connect them to care. Now, promote supportive workplaces. It's important that as organizations, flexible working hours, mental health days, let me give an example. There are organizations where an employee is not supposed to report to work. They're supposed to take a day off to take care of their mental health. It is called a mental health day. That day, they can't receive calls from the workplace because they're on a mental health day. They're supposed to be recharging. Then their employee-assisted programs. I wonder how many of our workplaces would be willing to have flexible working hours, mental health days for employees, and employee-assisted programs. So that, for example, a patient with depression, bipolar, with a substance use disorder, in addition to their usual medical cover, they also have probably support groups, or they have wellness programs which they can participate in. And this would really be useful as regards preventing suicide. Then corporate social responsibility. Our organizations can decide to support initiatives for suicide prevention or encourage employees to volunteer, so that they're either giving of their time or their skills to make sure that they're raising awareness about suicide prevention. Now, primary care. Now, it's important for us to look at what primary care looks like and why it is that we need to target primary care physicians in the prevention of suicide. Why? Because numbers don't lie. For example, if, for example, the people who die by suicide, they at one time or the other have been in contact with their primary healthcare provider. Either it's a GP or the medical officer or the clinical officer near them or the nurse near them, depending on which facilities they visit. And the numbers have shown that because of the fact that people have been in contact with primary care providers within a short time of their suicide, it is important that we target these people to ensure that they're able to identify the risk factors, identify protective factors, and recognize, refer to care, to specialized care especially, and to follow up these patients so that we reduce the amount of, we reduce the suicide. So what we are trying to say is the fact that if we look at a period between 3 months and the time of the suicide, most of the patients will have come into contact with their primary healthcare provider. So now, what are the best practice for clinician-led consultation? Let's learn to ask about self-harm. Let's not shy away from asking whether there are times when the patient feels that life has no meaning. Let's not shy away from asking them whether they've attempted to harm themselves. You will be surprised. You will find somebody with a long sleeve who never wears short-sleeved baby dresses or shirts. They're always in a long-sleeved clothing item. Why? If you ask them to like expose their wrists or the forearms, you will be surprised. Or even the thighs, sometimes you find that is where they get rid of their pain. During when they are feeling pain, that is when they use the blade, or that is when they use a sharp object to inflict pain. There are those who will probably have suicidal ideation. So they have been having ideas on how they can do it. There are those who will have been doing some research. They have even joined groups on social media, probably looking for the most effective way to die. So, but unless we ask that question, then we are not able to tell just by looking at the patient. Then we need to take disclosures quite seriously. And so that, for example, if a patient says, well, they have considered harming themselves, let's further that discussion. And let's see that we're able to evaluate the patient and find out what are the risk factors for this person, what are the protective factors, and what are their scores. Now, we need to discuss confidentiality because if, for example, a minor is talking about harming themselves, then indeed it is important to inform their parent that this person needs help and the fact that this person would benefit, despite the fact that they may not want you to share that information. It's important that we look at it as a psychiatric emergency and that the patient would need treatment. Then a non-judgmental, empathetic approach, and then we need to provide resources. Let's share with our clients if it's things like brochures or credible sites, which they can get information as opposed to AI or Dr. Google. And you find that they're getting all sorts of information, some which is not accurate. Then we need to organize follow-up when appropriate and with the same physician. I know this is a bit complicated. They're probably the primary care physician, one, has a lot of patients on their queue. Two, they may have a lot of workload and the time that they need to consult is a bit limited. But even then, it is still important to ask some of these questions, even in between your busy queue, and see that some of these people may not miss out on the care that they need. Now, when we talk about protective factors, I don't have a slide on this, but I would like to mention this. The fact that, one, it may be protective that a person feels that they have a sense of responsibility to family. They may feel because of their religion, then they may not want to end their life. They may have positive coping skills. They may have some positive social support, although now social support, we have to be very careful because the same people we are calling social support may be the ones who are leading to self-harm. They may be toxic, for lack of a better word. So it's important to find out who are these social support and how are they supported. Then the fear of death or fear of suicide is also a protective factor. Then fear of social disapproval. So when we are talking about screening patients for suicide, first and foremost is to talk about sad faces. So S will be representing the sex so that more males than females. If it's about age, if someone is less than 19 or more than 44, then that increases their risk. If there's positive history of depression, they have had a previous suicidal attempt, there is ethanol abuse, they have rational thinking loss. Like, for example, a patient who is hallucinating or who is deluded, that is a risk factor. If social support is lacking, that is a risk factor. If they have a suicide plan, they have an organized suicide plan, they're living on their own, so meaning they're single, they either are divorced, widowed, single, they have no spouse, then that may also be a risk factor. Then if they have sickness, like chronic illness or chronic pain. So what would happen is each of the sad faces gives you 1 point. So if you're male, you're less than 19, you have positive history of depression, you have had a previous suicidal attempt, you have been using alcohol, you're hallucinating, you don't have social support, you have an organized plan, all those are, they are a total score of 10 for the sad person. Now, if anyone scores between 3 and 4, then that means they have 3 or 4 of these factors, they need close monitoring. Should they be 5 and above, this is a patient you should consider admitting. And once you admit them to hospital, then this helps monitor them and also to plan treatment. Now, there are various resources which I would like all of us to have a look at. There is Live Life. It's an implementation guide for suicide prevention in countries. It's a 142-pager, but it is worth looking at suicide prevention, and this is across continents, across countries, and Live Life, the life, L-I-F, L is for the access to means, limiting access to means. I is interaction with media for responsible reporting. F is to foster life skills in young people. Please remember, foster life skills in the 15 to 29. And then E is early diagnosis or early intervention, identification and treatment of those in need. So that is one of the resources that is available online. It would be important to have a look at it. Then the Suicide Prevention Strategy of Kenya 2021 to 2026. It's also available by the Ministry of Health. And then it's important for us to remind ourselves that according to the World Mental Health Report, at least 1 billion people in the world are living with a mental health condition. So I would like to stop it there and go to maybe over to Dr. Soy for comments, Q&A, and thank you very much for your attention.
Thank you, Doc, for that comprehensive presentation, discouraging silence and shame around suicide and encouraging healthy conversations and best practices for clinicians. I don't see any questions on the question box, so I would encourage anyone who has a question to send through the question box so we can respond to the question. So this is the first webinar in the suicide prevention series that will be running throughout this month, every Tuesday. So make sure you log in. I would like to invite Dr. Ada, who is the convener for KMA Physician Wellbeing Committee, to maybe make a few comments and invite any KMA officials in the meeting, and then maybe she can send back to me to close. Karibu sana, Dr. Ada.
Thank you so much, Dr. Musheru. That was an amazing presentation. And to all of us who have joined in, I see we are over 200 of us. I hope that Dr. Musheru's presentation has ignited your compassion towards people who may be suffering with suicidal thoughts, and even be compassionate to those families who may have lost their loved ones through suicide. We will be continuing, as Dr. Soi said, we'll be continuing with this series for the next 3 weeks, learning on various aspects of suicide and how to handle better people who are around us, our patients, and even our loved ones. So I am hoping that we will all be able to log in for the next 3 Tuesdays at 7 p.m. as we continue with this discussion. Otherwise, I want to appreciate all of us for joining the meeting, and over to you, Dr. Asoi, to close us out.
Thank you, Dr. Ada. I see a lot of comments about how good the presentation was. Thank you all for attending this webinar. It was a good reminder on the significance of compassion, empathy, and kindness towards the goal of suicide prevention. The more we have these conversations and offer support to those at risk and those affected, the more impact we have on breaking stigma and fostering hope. Thank you so much once again, Dr. Musheru, for the wonderful presentation. It was very informative and quite eye-opening. Suicide is preventable, help is available, and together we can save lives. Thank you for joining, and let's meet each other next week on Tuesday at 7 p.m. Have a good night.
Thank you. Thank you for having me. Good night.